Hi, good morning. I'm Dr. Jo Garstang. I'm a paediatrician from Birmingham, England, and I'm a designate doctor for child death. That means I have the responsibility in my local area for ensuring that child deaths are investigated adequately according to our statutory guidance. And my team have been sort of leading the way for getting whole genome sequencing as part of routine for unexplained child deaths in England. So I'm going to tell you a little bit more. Apologies for not being here in person. It's actually about 2 a.m. In England now, and that's just too early for me. So in my talk, I think it's important we start with some definitions. Then I'm going to explain a little bit more about sort of what the potential benefits of whole genome sequencing might be, exactly what whole genome sequencing is, and then about our pathways for using whole genome sequencing in England. So, first definition, SUDI, because this varies according to where you are in the world, but in England and the United Kingdom, SUDI for us is the sudden unexpected death in infancy. So it's the sudden and unexpected death of an infant that couldn't have been predicted as a possibility 24 hours previously, or the collapse that led to death couldn't be predicted as a possibility. It is purely a description of the presentation of death, and it's not a diagnosis. And so currently around 2/3 of SUDI will remain unexplained, and a third will have a medical diagnosis following post-mortem or other investigations. The unexplained SUDI can be categorised as SIDS. So what is SIDS, or sudden infant death syndrome? These are the SUDI cases that remain unexplained. So the official definition is sudden and unexpected death of an infant that occurs during sleep. It remains unexplained after a complete post-mortem examination, medical history and review of the circumstances of death. The diagnosis of SIDS can include cases where there's a possibility of accidental asphyxia, so there's no reason why deaths occurring in a co-sleeping environment can't be labelled as SIDS if there isn't evidence to show that the baby's asphyxiated. What's really important though is a diagnosis of SIDS should not be reached by any one professional alone, but it needs a multidisciplinary case review. And in England and Wales we have about 200 SIDS per year. Here in England, we talk a lot about SUDIC, and by this we mean sudden unexpected death in childhood. Again, very similar definition, sudden and unexpected death of a child that couldn't have been predicted as a possibility 24 hours previously, or again, where the collapse leading to death couldn't have been predicted as a possibility. Again, it's a description of a presentation of death and it's not a diagnosis. However, unlike the babies, nearly all sudden unexpected deaths in childhood will have a cause identified at post-mortem or with further medical review. Final definition for us, SUDC, or sudden unexplained death in childhood. Similar to SIDS, sudden and unexpected death of a child that remains unexplained after a complete post-mortem examination, medical history and review of circumstances of death. Unlike SIDS though, it doesn't have to happen during sleep. Some cases of SUDC are witnessed cardiac arrests of children. There's approximately about 40 cases a year in England and Wales, but by far most common in the sort of youngest children aged 1 to 4 years. Unlike with SIDS, there are no recognised risk factors and nothing we can do to prevent it. There is, however, an association with febrile seizures in that these occur more commonly in children who subsequently die from SUDC. And there is a potential overlap with SUDEP, which is your sudden unexpected death in epilepsy. So why should we consider whole genome sequencing for unexplained infant and child deaths? So best estimates are at present that up to about 30% of these unexpected and unexplained deaths may have a single genetic cause. The diagnostic rate for sudden infant deaths can be up to about 20%, with the study by Newbeyer and colleagues showing that 9% of these were channelopathies. So those are mutations affecting sodium, potassium, calcium, sort of channels into cells, which typically cause cardiac rhythm disturbances. Cardiomyopathies in 7%, and these occurred where there weren't, where there was the genetic change, but you couldn't actually detect the cardiomyopathy on the post-mortem histology of the heart. And inborn errors of metabolism in a further around 1% that hadn't been picked up by the newborn heel prick screenings. Looking at whole genome sequencing for sudden unexplained deaths in childhood, so that's the group of children aged 1+, about 10 to 15% of these children will have either a brand new or inherited mutation in the cardiac channel or epilepsy gene. And again, 30% of these children have a history of febrile seizures compared to about 3% in the general population, although some recent study has suggested that actually a seizure may be a terminal event even without a history of febrile seizures. And again, it's well recognised that when you do histology on the brain, that there's hippocampal abnormalities seen in SUDC, almost half of the children, very similar to those seen in temporal lobe epilepsy, if you remove the temporal lobe for neurosurgery, or with deaths of sudden unexpected deaths in children with epilepsy. And again, the same hippocampal abnormalities have been seen in some SIDS cases. So again, looking at the similarities between SUDC, SUDEP and sudden cardiac deaths, that in SUDEP there's 25% of the children who die unexpectedly with epilepsy have got a pathogenic variant in an epilepsy gene, and 7% have got a likely pathogenic variant in genes that cause cardiac arrhythmias. And a very similar pattern is found in children who are known to have died a sudden cardiac death, having the same percentage have epilepsy gene variants. And it seems like these genes can either present as seizures or as cardiac arrhythmias. So why is getting a diagnosis important? Well, our best estimates at present are that using whole genome sequencing will get a diagnosis for around 20% of families. If a child dies and the cause of death remains unexplained, it's really difficult for families to process. They blame themselves, they look for all sorts of explanations, and they're absolutely petrified it will happen again. Even if you can't find a diagnosis for them, there's also often comfort for some families to know that their child's death has been fully investigated and no stone left unturned in looking for answers for them. If you do find a genetic diagnosis, it's really helpful to think about whether you need to screen other children or even possibly looking for in utero diagnoses. It can help reduce the risk of death, particularly with the sudden cardiac deaths. It may be that other family members need urgent cardiology referrals, and sometimes even sort of devices such as implantable defibrillators. And again, providing a recurrence risk for families. So what is whole genome sequencing? It's a detailed, in-depth genomic testing involving sequencing the genetic code from both the protein coding and non-coding genetic material. The analysis can take several weeks to months, and the interpretation is quite complicated. It may find a diagnosis detecting genetic changes that are associated with disease. It may find no changes associated with specific diseases. It often finds what we refer to as VUS, or variants of uncertain significance, where exactly as it's labelled, you find genetic changes, but you don't know what the relevance of these are. And you can also detect disease variants that you hadn't suspected that can have other health implications. Now, I better give an apology here in case there's any geneticists in the room cringing at this presentation. I'm not a geneticist, I'm a paediatrician, and this is a paediatrician's understanding of genetics. So what really is whole genome sequencing? Well, even though it's called whole genome sequencing, it doesn't really sequence everything in a person's DNA. The computer will catch the majority of the sequence data, but it doesn't analyse it all. It stores it, but it doesn't do the analysis on everything. That in England, what we do is we analyse by gene panels. So we may look at panels relating to a few genes or a few thousand genes, but you choose which panels you want to use according to the genetic phenotype. So what were the symptoms of the child? What's the family history? Were there any physical findings? And I've just put here at the bottom of the slide for comparison, the other thing people often talk about is exome sequencing. So exome sequencing involves analysing only the protein coding regions of the genome, and the exome is about 1% of the genome. Now here's some common misconceptions that firstly, just because there are genetic variation does not automatically mean that there's a diagnosis. There can be genetic variations, but it doesn't mean that the diagnostic label actually fits. And the next misconception is that just because you haven't identified a variant doesn't mean the condition isn't genetic. It's just that with our current technology, we haven't been able to identify it. So what are the different results that we might get from our whole genome sequencing? Well, firstly, we might get a genetic diagnosis for that child and their family. And this may well happen because with our different genetic diagnoses, you can have variable presentations, referred to as expression and penetrance through families. So although other family members may have the same genetic change, they won't have shown disease symptoms or won't have died suddenly. We might have a variant of uncertain significance where we don't actually know whether the findings are directly relevant for the death or not. Now we always try and get both parents as well as the child's DNA referred to as trio for analysis, or at least if it's a single parent, get a duo, so one parent and the child, because that helps us interpret the findings. But one thing that can happen is it will show up if a parent isn't who they think they are. We often may find incidental findings that we weren't actually looking for, but in the majority of cases, around 80%, the results will be negative with nothing significant found. But these are still very important for the research environment, and we're keen to recruit as many of our families into databases and registries for future analysis and comparisons. So how does whole genome sequencing work for us in England? We have a National Genomic Medicine Service that's part of the National Health Service, which means there's equitable access for everyone in England, providing they meet the sort of test criteria. And there's no charge for to have whole genome sequencing. It's covered by the NHS and it's covered from some central budgets as well, so it's not like it's a cost to the local hospital who might be requesting the test. So from April last year, SIDS and SUDC became an indication for whole genome sequencing in England. And we developed a gene panel, which the code number R441, where it's about 1,200 different genes we're looking at, looking for paediatric or syndromic cardiomyopathies, looking for cardiac arrhythmias and long QT syndrome, looking for early onset or syndromic epilepsies, and inborn errors of metabolism. And it's a balance of genes that are likely to be causing disease and variants of uncertain significance. So now I'm going to explain how whole genome sequencing fits in with our multi-agency investigation of sudden child deaths. So what happens in England is that when a child dies suddenly and unexpectedly, there's a joint investigation led by someone called the Sudic paediatrician, who's someone like me, along with specialist police, coroner, social workers, pathologists and specialist nurses. So all children, even if they've been declared dead at home, will be taken to the emergency department where they'll be met by paediatric staff. And we'll get a detailed medical and social history and account of what happened from the family. So typically that account is taken by someone like me, with a police officer sitting next to me to cover the police and coronial aspects, but it's very much seen as a medical investigation, with me taking the lead and the police possibly asking some questions, but wherever possible, it's absolutely paediatric led. We do a top-to-toe examination, police and paediatrician together, of the child, looking for any unexplained injuries, because we're aware that obviously some unexplained child deaths or unexpected child deaths may be associated with child abuse and neglect. And then we go and do a visit to the home or wherever the child collapsed and died. And again, that's a specialist paediatrician or specialist nurse along with the police. So we're doing a joint medical, joint police investigation. We then have an information sharing meeting held online, all agencies sitting around the virtual table together. We then have a post-mortem examination done by a paediatric pathologist, and when we've got the results of that post-mortem examination, along with any other investigations, we'll have a final case discussion where we look at all the information together to sort of agree a cause of death, identify any risk factors, any modifiable factors and any learning. We keep the parents updated throughout the investigation, and there should be bereavement support, particularly provided by our specialist nurses alongside of the investigative process. So how we do the whole genome sequencing as part of this pathway is that we take the DNA sample at the post-mortem examination. The DNA is extracted and then stored for later analysis. Only if no cause of death is identified are parents then offered whole genome sequencing. So that would be for deaths such as SIDS, SUDC, deaths classified as SUDEP because of the overlap with SUDC, deaths called sudden cardiac death or an unascertained death. Parents have to give consent for whole genome sequencing and provide samples. So we can't do it if the parents don't consent. And it's really important we get consent, particularly as there may be issues relating to paternity. That consent is generally taken by a paediatrician or a specialist nurse rather than through the clinical genetics service, because we know the families, we've seen them, we've got a relationship with them. However, if any of the genetic results are significant, families then will have follow-up by clinical genetics. But for the 80% where there's nothing of any note found in the whole genome sequencing, those results will be shared back to them by the SUDI paediatrician or specialist nurse. We have all results from whole genome sequencing stored with the rest of the child's child death review information, and that's collated nationally at our National Child Mortality Database as well. So, in summary, whole genome sequencing has potential to help find diagnosis following unexplained infant and child deaths, but it's really important. It's part of a specialist investigation process and can't be sort of standalone. It has to be part of our multi-agency process, including post-mortems, medical histories, and social investigations. that it's important that the people taking consent and discussing whole genome sequencing are trained and understand about that. And also it takes more time, so it's got to be resourced properly if you're going to have the SUDI paediatricians and specialist nurses doing this rather than clinical geneticists. And it's also really important that we have national data collection to help us with our ongoing interpretation of results and for future research projects. Thank you very much, and I hope the rest of your conference goes well.